Welcome, everybody. This is the EANS tumor section speaking, so to say, and welcome to today's webinar. We are trying a new format for the first time, a journal club, and this is why the title is Neurooncology News Journal Club. We have recruited two people who will present papers that they feel are important, and they want to share their opinions, they want to share the data in the paper, and then we are looking forward to lively discussions. Please put your questions down in the Q&A section, and I will try to read them and then read them out aloud, and then we'll discuss that. I think we're in time. So the first speaker, this is what we discussed, will be Dr. Quach from Germany, from Bielefeld, actually from my department. And Dr. Quach will present the first paper. It is about gliomas. So Dr. Quach, please.
Can you see the presentation?
We can see it all right.
Okay, so thank you for the opportunity to discuss with you some compelling data about the interactive effects of molecular, therapeutic, and patient factors on the outcome of diffuse low-grade glioma. As probably everyone in the audience knows, in 2012, Jakola et al. Published their landmark paper comparing two hospitals with different strategies regarding treatment of low-grade glioma patients. And what they could show at the time was that preferred resection in Hospital B resulted in a strongly improved survival compared to Hospital A, which favored watchful waiting. If you look at the histologies, the tumors that they included at the time were grade 2 astrocytoma, grade 2 oligodendroglioma, and grade 2 oligoastrocytoma, as was of course common. And since then, the definition of what constitutes a grade 2 astrocytoma or oligodendroglioma has shifted with the CNS-WHO 5 classification, where low-grade glioma are molecularly defined now. So we have astrocytoma IDH mutant and oligodendroglioma ADH mutant and 1p19q co-deleted, and some formally classified low-grade glioma, which are IDH wild type, would now be classified as glioblastoma. So it stood to question whether the benefit of resection that was shown for low-grade glioma at the time is retained among those molecularly defined subgroups, that is without the IDH wild type tumors, and also if all those molecularly defined tumor groups would benefit equally from a maximal safe resection, early maximal safe resection. And for this, to answer this question, the group around Hervé Jumper recruited 392 patients across 3 centers with grade 2 astrocytoma IDH mutant or oligodendroglioma ADH mutant 1p19q co-deleted in the development cohort, and they also included a validation cohort of 365 patients. And with these cohorts, they did a recursive partitioning analysis using all known prognostic variables, including extent of resection, and they also did a propensity score analysis of the combined cohorts to mimic a controlled trial. I would have loved to not include a long list of patient characteristics in the beginning, but all my attempts to summarize them ended up needing almost all of the table in the end. So I will just like to point out some parts of the table that I find interesting. The first would be the age at diagnosis. Of course, this is a low-grade tumor cohort, so the patients are young. Their median age is 38 years. But this is interesting to know or to keep in mind because of the cutoff of 40 years for certain treatment decisions as recommended in the EANO guidelines. There's some idea that low-grade glioma patients should not be 60 years or older, but in this cohort they had 4%. Whether this is a high or low number, I think could be matter of discussion, but this is the patients that were included. considering tumor location, which is something that, of course, influences extent of resection, they chose to classify it by the hemisphere, like left or right side, and classify the location by the lobe, frontal versus temporal versus parietal versus insular, and not go into more detail regarding, for example, eloquent location. For the clinical status, they classified it with the Karnofsky score, and they used subgroups of Karnofsky 100, 90, or less than 80. There also, it's maybe interesting to keep in mind that almost a third of those patients had no information about their clinical status, so could not be included in any analysis of that kind. Among those patient cohort, about half of them were treated with chemotherapy along the course of the follow-up. And among these therapies, the by far most common was treatment with temozolomide. This is, I think, interesting to note that the rates of chemotherapy with temozolomide were almost the same in the astrocytoma versus oligodendroglioma cohort. Interesting for me to keep in mind, because the EANO guideline that they also cited in their paper would recommend for oligodendroglioma, depending on the prognostic factors, to do radiotherapy followed by PCV chemotherapy, and only in select cases use temozolomide. The preoperative, no, wait, this is, no, I can't see my own presentation. So radiation was received by a little less than half of the patients, especially in the astrocytoma group, a little less in the oligodendroglioma group. The median preoperative volume was 35.9 milliliters, and 1/3 of the patients had a low tumor volume of less than 25 milliliters. Postoperatively, there's a very high rate of complete resection with no residual flare hyperintensity left of 30% in the whole cohort, and comparably between the two glioma subgroups. And also another third of the patient had a near total resection with less than 4.9 milliliter residual tumor volume. Among those cohorts, of course, low-grade glioma have a slow progression. So it's interesting to note, or it speaks to mature data, that 40% of the astrocytoma patients and 16% of the oligodendroglioma patients did succumb to their tumor within the time of follow-up, and almost 60 to 70% had a progression or a malignant transformation in more than 20%. So what were the results that they could find in this cohort? They could follow it up for 11.7 years in median, which is quite impressive for such a large cohort over 3 centers. The median overall survival was 19.9 years. And progression was seen in 202 patients and malignant transformation in 66. So what they wanted to look at was the prognostic factors and which would influence overall survival as the primary endpoint. And they put into their repetitive partitioning analysis all known prognostic variables, including age at diagnosis, sex, tumor location, chemo or radiotherapy, tumor subtype, pre- and post-operative tumor volume, as well as extent of resection independently. And what the analysis came up with was a decision tree finding the most important factors for overall survival were post-operative volume, with the cutoff being 4.6 milliliter, the pre-operative volume with the cutoff being 43 milliliter, and the tumor subtype astrocytoma versus oligodendroglioma, as well as chemotherapy. And with these factors, they could differentiate the tumors into 3 subgroups of different prognosis. With the worst prognosis being astrocytoma patients with a larger residue, the best subgroup being either oligodendroglioma or astrocytoma with a low preoperative and postoperative volume, which did not need to receive chemotherapy. And the patients with intermediate subgroup were oligodendroglioma patients with a larger residue, or patients that were given chemotherapy according to physician's choice. And this will sum up the different groups again. In this chart, it's interesting to note that the addition of chemotherapy seemed to have a negative statistical effect on overall survival, although the authors do note that those patients that received chemotherapy tended to have both larger postoperative and preoperative volumes. So those were tumors considered to be at higher risk for progression by the treating physicians. And this is how the authors explain this negative prognostic effect of chemotherapy. If you divide all patients of the development cohort into these three groups now, you can see that there's a strongly significant effect on overall survival, with group A having the worst and group 3 having the best prognosis, group 2 being intermediate. This could also be validated by the validation cohort, which again showed the differentials between the three groups. One could argue, of course, that these groups do differentiate the tumor subtypes that we know have a different prognosis, right? The oligodendroglioma have a better prognosis than astrocytoma by and large. So is this due to the subgroups being part of the partitioning analysis? If you look at the molecular subgroups of the developmental cohort, you see that the effect of these three subgroups is retained among astrocytoma, and this only includes two subgroups because group 1 is only astrocytoma patients, and among oligodendroglioma patients. So these molecular subgroups, which especially rely on tumor size and extent of resection, are retained among the molecular subgroups, both in the development as well as the validation cohort. They also looked at the effect of gross total resection. For this, they pooled all patients, both of the development and validation cohort, and defined gross total resection if the volume of resection of the flare hyperintensity after the resection was 0, and they defined gross total resection plus a supramaximal resection if the extent of resection extended beyond the flare hyperintense tumor margins. If you then compare the whole cohort with these three extents of resection, then you see that the supramaximal GTR plus had the best overall survival, and the maximal resection and the submaximal resection had a similar overall survival, with the gross total resection being slightly better. This effect pertained especially to astrocytoma. So if you look at the subgroup of astrocytoma patients, you see a benefit of supramaximal resection pertaining to overall survival, while the difference in gross total resection versus subtotal resection was not statistically significant. In the oligodendroglioma, this differentiation did not reach statistical significance, although if you look at the curves, one would expect that either gross total or supramaximal resection did seem to have some effect compared to subtotal resection. They also checked the risk factors: post-operative tumor volume, LGG subtype, preoperative tumor volume, and age at diagnosis for progression and malignant transformation. We remember that many patients in this cohort had progression over that time, so the data are mature for that. And again, glioma subtype as well as post-operative, this should say preoperative, I'm pretty sure, preoperative and post-operative volume are the most important factors that they could find to differentiate progression-free survival in this grade 2 glioma group patients. If you look at time to malignant transformation, that is transformation from grade 2 to grade 3 or 4, it again depends on the post-operative volume, and also astrocytoma being more likely to progress than oligodendroglioma. And interestingly, the preoperative volume and also age at diagnosis come into play here, with age at diagnosis of less than 43 years having a worse prognosis, considering risk of malignant transformation. This is interesting to note because, of course, we traditionally viewed the age of more than 40 as a negative prognostic factor for patients overall, which the model could not show in this case. And here a young age seems to be a negative prognostic factor for malignant transformation, although this could be biased by the residual lifetime. This will probably need to be investigated further. To come back to the extent of resection, they also did a propensity score analysis to mimic a prospective study where they matched the patients from all cohorts depending on age at diagnosis, tumor subtype, therapy, preoperative tumor volume, and tumor location to kind of exclusively investigate the influence of the extent of resection. And you can see that both for overall survival, progression-free survival, and time to malignant transformation, there is an incremental effect of an increased extent of resection. So the more of the tumor is resected, the better in this diagram, and it reaches statistical significance for overall survival by an extent of resection of 75%, and similarly for progression-free survival at 80% and time to malignant transformation at 70%. This, I think, is a very impressive figure to show that even these increments actually matter. Okay, so to sum up, an extent of resection of more than 75% in their cohort correlates with improved overall survival in all low-grade glioma types, independently of preoperative size or adjuvant therapy. There is an incremental increase with extent of resection, and both a larger preoperative, more than 43 milliliter, and a larger post-operative, more than 4.6 milliliter tumor volume were associated with worse overall survival. The authors also conclude that resection beyond the imaging-defined tumor margins improves survival outcomes, with greatest benefits seen in patients with astrocytoma. But in my opinion, they should have included a little more information about what resection beyond the imaging-defined tumor margins, how it is exactly defined, and how it could be achieved. What should be discussed, in my view, about this paper, but I'm also open to any more suggestions. Of course, it's retrospective data, especially important in the consideration of the chemotherapy treatment, because from the RPA analysis alone, one could argue that chemotherapy would be worsening the prognosis of the patient. But of course, this was not a randomized study in that respect, and chemotherapy treatment was rightly chosen by the treating physicians in tumors that were more likely to progress. I would question the clinical use of the RPA, because I cannot see in the clinical context grouping all low-grade glioma patients into these groups to prognosticate them, because we will probably continue to look at astrocytoma and oligodendroglioma independently. The definition and therefore effect of supramaximal resection is, of course, I think a matter for further debate. So they showed in the supplement that the patients who did receive this supramaximal resection did tend to have a lot smaller tumors. So there's, I think, some bias that cannot be eliminated, because you cannot achieve supramaximal resection in a large number. In a large number of these patients, and this limits the applicability, which is, of course, limited to resectable cases, which were the only ones included. And there was, of course, no reference made to function and extent of resection with regard to optimal retainment of function. Okay, thank you for your attention, and I'd be happy to discuss the data and any questions.
Well, thank you very much for the very enlightening presentation of the paper. Let me have a look. If somebody from the audience, there don't seem to be very pressing questions. Again, to the audience, if you have a question, please write it in the Q&A section, and I will read it out aloud, and then we can discuss this issue.
Maybe I can start with some comments, because
oh, yes,
the
please.
question have not been opened. For your concerns, Dr. Quack, I think, yes, it's a retrospective trial, but I think that's almost the best we can get in these patients, because a prospective trial in these patients over 10, 15, 20 years, it's not feasible. But at least we will not see the results from that. So I think we can be happy to have such data from such a large cohort that has been investigated extensively from a statistical point of view. Even though if some of the statistics are quite difficult to understand, at least to me, I think you pointed out the principles very well. I also think that ensures us in our daily business, because I think there's nothing new, and so we should go for a maximal resection, maximal safe resection, also in those patients. Supramarginal is debatable as all the time. So we discussed that in all tumors nowadays, even lobectomies. But in all these trials, we are missing clear definitions, what means supramarginal. But in this cohort, with your last slide, you show perfectly. Of course, you will go for a supramarginal if you have a really small tumor in an eloquent area. That's quite easy. But these tumors seem to go better than the big ones, obviously. And of course, what I learned, it's not that changing, that we should be more aggressive with astrocytomas, given that they do not respond so well to adjuvant therapy. And also in this analysis, they seem to perform worse, especially if we have larger residual tumor. So even though there's this big data and a little complicated statistics, I think we do not learn so many new things, but it reassures us in our clinical practice, I think, at least for our clinic. That reassures us and gives us data to argument for our decision towards aggressive surgery. But thank you for that nice presentation of all the data. It was quite nice workshop. Thank you.
Exactly. Thank you. That was the similar conclusion that we also drew from it with the new WHO classification. I think there's a lot of questions how we should now treat tumors that we thought we knew for years, and it's reassuring to know that some of the rules that we learned over the years still hold true, although it does probably make sense to look into some more detail, especially with regard to supramaximal.
I think I share very much your conclusions and concerns. I don't like the RPA thing so much. RPA in my world has to do with brain mets, right? There was a classification, and that was something that could be used in a clinical setting. The prognostic groups that were identified or characterized by RPA, I have problems remembering them and using this system. And by the way, Dr. Kraft, I seem to remember that the RPA, the classifying parameters were different for the survival outcomes. So for overall survival, that was different than for progression-free and for malignant progression-free. Do you have any opinions on that? Is this real, or is this a statistical artifact?
This is also something that I thought about, and I think it's a little difficult to explain, but I think it pertains to tumor biology as well as adjuvant treatment that is not represented in the time to progression or time to malignant transformation, but is, especially in oligodendroglioma, of course, is very important for overall survival, as they respond so well both to adjuvant treatment as well as salvage treatment in the case of recurrence, which is of course lost in the time to progression.
Thank you. There's just some other thoughts. I've found it interesting that when we're talking about extent of resection, the percentages, in this case 70, 75, 80% and so forth, they're not that dissimilar from the percentages that have been published by others in other settings with other series, when they wanted to show where is the cutoff? What do I have to do? Is a third of the tumor okay? Is half of the tumor okay? I think something like 3/4, 75, 80%, so a lot of the tumor, then we start seeing some benefit. So I found that comforting, because this probably is what we all do. We will probably not operate a tumor and say, hey, this is a resection, and we take out a third. No, we will take out a lot more, and yes, we're happy to do more and so forth. Some thoughts about the oligo thing. I think you showed that the degree of resection does not matter as much, or resection does not matter as much in oligos, but it matters some, right? It is not without influence. So, well, my personal opinion would be, yes, I will go on and resect oligos. And yes, I think I like what Dr. Kerschbaumer said, that I will resect astrocytomas more aggressively, but I will still go and try to resect oligos, do a safe resection, but if I have a good EOR, that is probably preferable or something else.
I think just a comment from me. I think we're seeing the same effect as we're doing in brain mets, which I will talk about later on, where you have data on extensive resection is linked with a better overall survival, but in brain mets is radiotherapy. In oligodendroglioma, there we have chemotherapy that may come up with some surgical shortcomings. So therefore the effect there may be less than in astrocytoma. That's my thought on that. But still, as you see in the diagram, there is an effect, even though it's not that big and not that clear in between the groups. But as Dr. Quach stated, you see also here an effect in between the gross total / gross total plus group and the near total or subtotal group. That's my comment, my opinion on that.
All right. There's maybe one last question from my side. When I read the paper, I at least I can't remember that degree of resection was also investigated, talking about subgroups, and the authors investigated histologically defined subgroups against the background of adjuvant therapy. So you know, if there's something that I would like to criticize concerning the paper, can I somehow, if I don't resect the patient completely, is this more of a problem if there's adjuvant therapy or not? So again, so was somewhere in the paper degree of resection, GTR plus or whatever, investigated against the background of adjuvant therapy? Can adjuvant therapy substitute for degree of resection? I think this was not in the paper, but Dr. Kwok, you've probably read the paper much more carefully, so please can you comment on that?
As far as I understood, they controlled for adjuvant therapy in their comparisons, but they did not compare the resection versus therapy subgroups. But of course, you can read the partitioning analysis in a way that would suggest that extent of resection is more important than, for example, radiotherapy, because it was included in the factors that were investigated in this. So if all we had were the data from this paper, then one would probably suggest that radiotherapy cannot make up for a lower extent of resection. Neither can chemotherapy, but the data did not specifically address this question.
Okay, thank you. Let me have a last look at the Q&A section. And so everybody's happy? Okay. I guess thank you very much, Dr. Kwok, for the fine presentation. And the next speaker is Dr. Kerschbaumer, and he will present 2 metastasis papers, and then we'll discuss metastasis. Please, Dr. Kerschbaumer.
Perfect. So thank you for having me here and giving a short presentation. So my papers are not so high educated as the last one was, given that they are surgical papers about brain mets. It's still important to us, an important topic, because of the high incidence of these tumors. They are more common than gliomas themselves, 10 times higher incidence, even though they require less frequently a treatment from our neurosurgeons. You see that also over the time that due to involvement of radiotherapeutical methods, the position of us neurosurgeons has lost power. So from just given the caseload, even though that we knew since 1919 that we can do good for patients suffering from brain mets by resecting them, which has been shown in this trial of Paschal in 1919. There's some ongoing discussions why we have such high recurrence rates. Infiltration is one point that's still debated and has been shown in 2013 from a working group of Vienna, in half of the patients at least. So therefore, still radiotherapy has a fixed role in treatment of brain mets. When I started neurosurgery, it was mostly whole brain radiotherapy. That nowadays, I think it's obsolete in most of the cases. Not complete, but everyone tries to withhold whole brain radiotherapy due to neurocognitive decrease over the time with prolonged overall survival. So it's used mainly for symptom control in leptomeningeal disease and focal radiotherapies, so radiosurgery on the first line, or radiosurgery or hyperfractionated radiosurgery to the tumor bed has become the standard of care. These two changes over the last 10, 15 years have raised two main problems in my opinion. So by withholding whole brain radiotherapy, we see more leptomeningeal disease, and this leptomeningeal disease is another one that we learned during our med studies, because it consists of a nodular leptomeningeal disease and not the classical sugar coating that we see as in end-stage cancers. And we have to deal with this problem as well. And the focal radiotherapies come along with a higher rate of radionecrosis that we see during the courses, that come along with clinical problems for the patients themselves, but also diagnostic problems for us that we have to evaluate the MRIs during the course of the disease. So therefore, it's neurooncological news. I choose some small publications from this year. And I will start with a paper of Oxford around Ehab Shiban, who evaluated their series of intra-radiotherapy using the size intrabeam, which closes the gap of surgery and postoperative radiotherapy after wound healing. So speaking of weeks after the therapy, we still have to withhold systemic therapies and all that stuff, and closing that gap by bringing radiotherapy directly in the OR and applying it to the resection cavity immediately after surgery. Quite impressive number with this new technique. 105 patients that they included in their series. Of course, most of them in RPA class 2, but also class 1 and 3. And they could show that even larger metastases could be included. So they included metastases up to 7 centimeters in diameter. You have to know that you have to fill the cavity with a applicator. So and those applicators range up to 4 centimeters, but they could successfully treat also lesions up to 7 centimeters. Also in more metastases simultaneously or one after the other. So resect one, go for radiotherapy, go for resection of the second one, and proceed similarly. And they could show that they had quite a good overall survival. So still patients with brain mets, most of them do not live longer than a year. We had here a median overall survival of 18.2 months. And an excellent control rate, I think, with 19.5%. Important for me, leptomeningeal disease in less than 6% is quite low. So most of the series I am aware of describe leptomeningeal disease in 10 up to 20. Some series also more than 20% of resection followed by focal radiotherapy. And of course, in this series, a very low number of whole brain radiotherapy in the course of the disease. Also, the technical data I find quite good, because the prolongation in the OR, so time that we cannot operate, it's every time a concern of us surgeons, is not more than half an hour with a radiation time of 15 minutes mean. And also the other concern I rose earlier on, radiation necrosis, was seen only in 3 patients, 2 of them completely asymptomatic and self-resolving. This group reported quite a high rate of incomplete resection of over 30%, but there are other series with even more residual disease in brain mets, and they discuss if that could be due to changes of the contrast extravasation after surgery and direct radiotherapy. Important for the patient, even if they had a higher rate of incomplete recession compared to their own previous series, they had unequal local control in their series. So in my opinion, strengths of this study, even it's just a descriptive analysis of their series, that we have a large cohort on this technique. It's the largest series I know with this technique, with a good local control and low rates of leptomeningeal disease and radionecrosis. Of course, as I told, it's retrospective and monocentric, and the authors themselves state that they have a relative short follow-up, given that many cases were operated in the last 2 years. So we have a time of analysis, almost half of the patients still alive. And as reference, given that we have no randomization, they had to use their historical data, which raises bias, obviously. I jump quick to the next paper, and we will discuss both papers afterwards. That is a paper published this year from colleagues in Switzerland, in Aarau, the pre-op trial, which puts radiotherapy before resection, and in that intention of the study group, immediately before surgery, in order to sterilize, neutralize, you may call it as you want, the brain mets before surgery. So they included patient with symptomatic with brain metastasis that they thought would be good candidates for surgery, but went for radiosurgery immediately before the surgical resection. It's a feasibility trial, so it's not powered for any outcome measurements. They only included 13 patients, and only 12 received the radiosurgery before resection. A little smaller, of course, given the limitations of radiosurgery. So they just included brain mets up to 4.4 centimeters, and not 7 as the Augsburg group did, and went for radiosurgery according the needed dose of mean 16 gray. They started off, as they described, by applying radiosurgery and going thereafter straight to the OR, but felt that this was not feasible especially for the surgical department, because you cannot plan it as exactly as you wish as a surgeon. So thereafter, they put the radiosurgery one day, some days before the surgical intervention. In median, it was 1.5 days, but it could be even a week before the surgery. And as I stated earlier on, this trial is completely not powered for outcome measurements, but descriptive. Also here, we see no leptomeningeal recurrence in that limited data set, and good local control as well with 83%. So just shortly, the inclusion-exclusion criteria: mets up to 4 centimeters in diameter. Could be used also in multiple metastases. They included up to 3 brain mets, all 3 treated radiosurgically, 1 resected. They included only cases where they anticipated the gross total resection, and patients where they thought they had a prognosis more than 6 months to look up how this could affect imaging and clinical course of this patient. Of course, no contraindications for MRI and steroids, and as always in oncology, KPS over 60 was mandatory. Of course, tumors sensitive to radiation therapy were not included, and also patients who had pre-treatment, especially with whole brain radiotherapy, were excluded from this trial. So if you look at the endpoints, the primary endpoint was feasibility of this technique, and the secondary endpoints were clearly underpowered. So regarding feasibility, it could be conducted in 12 out of 13 patients. One patient could not do it, but that was an organization problem of the department and nothing else. So from a technical point of view, it was feasible in all patients, and you have to take these information with care, because not powered for it, but the local control was good. Also, leptomeningeal disease and radionecrosis was another concern in that trial. So limitations: it's a very small sample size, a single center design that was only powered to see is it feasible technique, and the follow-up data is incomplete, but we're hoping to hear from that group again. They started a multi-center European trial now with the PREOP2 trial, where they recruiting, we're taking part of that trial as well, and hope to get the results from that trial and see whether this technique is something to catch up. It sounds promising, and there are Italian and French groups as well conducting similar trials, and we'll see if that holds up. So just as a conclusion, two promising techniques described in papers this year for brain mets, trying to combine radiotherapy and surgery, and that in a very short time point, so that we do not interfere on one point with the quality of life for patients. So most of the patients are very grateful for these techniques, because surgery and radiation takes part within a short time, and they are free to go afterwards, free for further therapies, have not to stay that long in clinic, with a good local control, and as far as we can tell from these two papers, with good rates of the, in my opinion, most difficult problems of radionecrosis and leptomeningeal disease in such patients. So, thank you.
Well, thank you, Dr. Kerschbaumer, for the really nice presentation. I will have a look at the Q&A section. There don't seem to be any pressing issues. Again, to the wider audience. Yes, of course. But I just wanted to invite everybody again. You know, it's not just that we have to discuss these papers. Please, everybody else, if you have questions, pose your questions, and we're happy to discuss them, share them, and not to answer them. Please, Dr. Quach.
Thank you for the presentation of these very promising, so to say, new techniques. I was wondering, especially in the pre-operative radiosurgery paper, this is something that could actually, if this works out, this could actually be applied to a lot of centers, because you don't need a special machine that you need to buy before. You don't really need to change the routines that much, just the order the patients are treated. I was wondering, as far as I understood radiotherapy, there's a delayed effect of radiotherapy on the tumor and on the adjacent brain. There's some immune interactions, and at least I think we're telling the patients that the radiotherapy is still working after the days of treatment are finished. What was the rationale of making this time between the radiotherapy and the resection so extremely short? So why 1 day or less than 1 day, and not maybe a few days or a week, to increase the time that the radiotherapy could have had an effect. I wonder if we don't lose some effect of the radiotherapy by taking out the treated area, so to say.
So it's not particularly described in these papers. So it's just my personal opinion on that topic. So the aim of this trial was mainly to get a radiosurgery to the tumor bed. So if by prescribing, call it 90 or 80% to the tumor itself, you will have a certain irradiation of the tumor bed as well. And if you do that after the surgery or right before, it does not matter. So the only rationale to go for radiosurgery of the tumor bed within some weeks after surgery is that we wait for the wound to heal, so that we have no complications there. But ideally, we would like to go for a surgery if indicated, and afterwards, knowing that we have a high recurrence rate, go as soon as possible for radiotherapy to prevent recurrence. So it's in this setting, the preoperative radiosurgery is not thought to have the same goal as the primary radiosurgery, but it should substitute the post-op radiosurgery to the tumor cavity.
Okay.
So therefore, it's a little different from those prescribing and similar thing. But you're right. The authors mentioned the biochemical changes in the surrounding area, but they do not describe that extensively. So I cannot answer that. But that's my these are my thoughts about that.
Thank you. Also, with the intraoperative radiotherapy, I was wondering. So, from what I know about radiotherapy, the radiotherapists are all about treatment planning and dose planning and treatment volumes. Did they retrospectively make it their diagrams and treatment curves? Because it is possible that some patients will need some further radiotherapy further on, right? And did they mark exactly where within the brain the center of the radiotherapy was, or could you retrospectively model which area got what dose, or
Yeah,
do you get what I mean?
The technique is quite nice.
Is it navigated or
it's navigated? It's navigated, and the technique is quite nice for every radiotherapist, I think, because it forms every cavity into a perfectly round shape, because all the applicators are round. So therefore, those distribution and everything is perfectly geometrical, which makes calculation of the dose and the adjacent dose quite easy.
Okay.
But when you think about the machine itself, it's a navigated applicator that you can put in, and therefore you can calculate the doses for all that stuff retrospectively. So it's not described in the paper, but this technique, you can plan the whole radiotherapy right before operation, given that metastases are not so diffuse in their growth centers. They have a quite clear margin that you can rely on, so you can do some of the planning already preoperatively.
Thank you.
There are two questions in the Q&A section. One refers to the intrabeam study, and the question is, did the colleagues mention issues with edema pre- and post-operatively? So are there any edema issues, things that were...
They described no big problem with this technique. So radionecrosis in 3 patients, but not other big issues that they described with that. They got or they were treated with steroids, but they do not discuss that extensively what regimen they followed for the steroid treatment.
One question from my side for the intrabeam people would be, I think that they also published, like local complication rates. Did they see infections, bone flap infections, poor wound healing, and so forth? Could you comment on that?
They describe it as literally no adverse effect of this technique. So they described some adverse events and perfectly explained why everything else was the problem, but no, at least in this series, they described no adverse event they could relate on this technique.
Then the second question from the Q&A section is it safe for surgeons to operate patients irradiated the previous day or week? I think this is a more general question. I would say,
and I would say yes.
Yes, it is. Yes, it is safe, but maybe you have a somewhat higher rate of wound complications. So I'm not, at least I wonder if you are, I'm not aware of any study or any figures that I could quote.
Same here. So it's perfectly safe. So you let them walk out even after radiosurgery, so that there's no issue with that.
Yeah.
And the rates I know of wound problems are obviously less in radiosurgery than they are in classical fractionated radiotherapy over a longer period.
I think it's not about the patient, but for the surgeon. I mean, there's nothing radioactive implanted into the patients that could be a danger for the surgeon. I think it would be different for some nuclear medicine or maybe brachytherapy where there are radioactive implants, but after radiotherapy, the patient itself is not radioactive.
So the only concerns you have if you do that within your OR, you have a special shield because you bring in radiation into your OR. So that may you have to have some restrictions there, of course, during the application of the radiation, but otherwise there's no concern regarding that.
I have one. Well, it's more a comment than a question. If you do intrabeam radiation, essentially you don't wait for the histology. So every once in a while you will radiate something where radiation may not have been completely appropriate. Yes, I've read the paper. So I seem to remember that they also included some histologies where you would usually say, like melanoma and renal cell carcinoma, where you would usually not, at least not all the times, prescribe post-op radiotherapy. Any thoughts on that in the paper?
In the paper, not. So they described it. They did frozen section to exclude other malignancies other than metastasis. But of course, they had no histopathology at all to subdivide the patients. But you're right. That is one issue that has come up, that due to good systemic therapies, especially in melanoma, some lung cancer, and also in breast cancer, you tend to withhold radiation therapy completely, but that differs from centers. So in our center, if we're going for local control, we still go for radiation of the tumor bed, even in melanoma. Even if we see other small metastases and keep them away from radiotherapy and go down with systemic therapy, if we operate on a brain mat, and I would say in over 90% will go still for irradiation.
Okay, there's just one more, comment or question in the Q&A that I don't, maybe not fully understand. I think it's again about safety and safety of intraoperative radiation. And what about safety issues? Maybe this is the question. What about safety issues, for the surgeons involved when you do intraoperative radiation.
So that's what we discussed. Is nothing implanted, so the surgeon practically leaves the room during radiation application, and the radiotherapists guides this part. Mm-hmm. So there's basically no problem or no risk for the surgeon.
One more questions, and there we seem to leave the metastasis topic. Glioblastomas, multifocal glioblastomas. Are you aware of similar concepts for gliomas and glioblastomas? Maybe let me pose the question like that. Historically, there has been something quite a while ago where I was a lot younger, where people had something like a balloon, and they installed some radioactive isotope into the balloon, and then the balloon was in the brain. That was very bad in terms of prescribing doses and so forth. Any comments on that? Or are you aware, since you look through the literature apparently, are you aware of anything for intraoperative radiation for gliomas? Is there anything going on?
Nothing radioactive. I'm aware of that is used nowadays. There's still the wafers Americans try to implant in glioblastoma and all that. But if I understand the multifocal glioblastoma radiosurgery, there's no place for that in diffuse glioma. No?
But what about intraoperative? Is there? I can't remember. I know I should. Is there something about something going on about intraop radiation for gliomas? Does anybody know?
I know that they discussed it, but radiation. No, I'm not aware of any.
Okay.
I'm sorry.
So can't solve it right here.
Yeah.
Okay. Looks like we have at least tried to answer all questions. And then, well, thank you very much again, Dr. Kerschbaumer, for these very nice presentations. And we will find out what comes out of that. And if so, from this side, maybe, you know, when we lose radiosurgery to the radiotherapist and we become radiotherapist to another door, whatever, we'll see. Thank you again. I think the last speaker for today will be again Stephanie Croix, and now this is about meningiomas, so third big group of oncological and neurooncological diseases. Please.
Okay, thanks again. So last but not least, I'd like to discuss with you a neat analysis that my former colleagues from Munich, Dr. Teske and Dr. Überscher, did about a postoperative dotatate PET-CT imaging for prognosis and progression-free survival in grade 1 meningioma. And of course, we all know the Simpson grading, where with increasing extent of resection as defined by the surgeon intraoperatively, the rate of recurrence can be predicted to some extent, as Simpson published 1957. And the Simpson grade is still in use today, although there is literature pro and contra using it in this day and age. There are groups that found no significant differences in recurrence-free survival between patients receiving a Simpson grade 1, 2, 3, or 4 resection. There are groups that described that Simpson grade 2 resections did not progress significantly at a greater rate than Simpson grade 1. Some groups found no significant differences in recurrence rate between Simpson's grade 1, 2, and 3. I think that partial removal has a higher recurrence rate than complete resection is out of the question. This has been shown, but especially in the lower grades, there's some debate how extent of resection should be described and how it should be managed. There was a recent review which concluded that rather than relying on an intraoperative assessment of surgical accomplishments, prognosis should be determined based on the presence of residual tumor and its volume on postoperative contrast-enhanced MRI, location, grading, and histopathological and molecular subtypes. They kind of contradict their conclusion with their own graph, I think, which does tend to show in all the different papers that they summarized a tendency toward lower risk of recurrence with an increase, with a lower Simpson grade across all groups if you look at it visually in this way. Their conclusion to use MRI instead is, of course, also questionable. The MRI differs from the idea that the surgeon had during the operation. There are cases where the MRI is more favorable than the surgeon, and there are more cases where the MRI is less favorable than the surgeon. But also it's difficult, especially during follow-up, it's difficult to distinguish a true tumor remnant as compared to scar tissue. Nowadays, there are more ways to visualize meningioma, and one of special interest is the dotatate PET-CT. This relies on the high expression of somatostatin receptor 2 in meningioma, especially in grade 1 meningioma. And as Dr. Rachinger could show several years ago, there's a very high sensitivity of dotatate PET-CT to delineate meningioma, specifically also compared to healthy dura, to bone, and to also scar tissue. This corroborates with an incomplete resection. So in a Simpson grade 4 resected tumors, PET could detect the tumor left by the surgeon in 100%, whereas MRI was not always able to detect the tumor. And also PET did detect something that was interpreted as tumor even in Simpson grade 1 and 2 resections. So there was a discordance between the surgeon and the PET in 30%. Particularly, the surgeon tended to estimate a better extent of resection than PET. But of course, this correlation alone does not tell us of the clinical relevance. It does not tell us whether these PET positive tumors or whether this PET positive areas would actually be tumors that would grow during follow-up. And this is where the paper comes in, which looks at progression-free survival after meningioma resection and dotatate PET-CT. And it could include 46 patients with 49 tumors, and divided it into patients with a tumor remnant on PET-CT, with 26 patients, and 20 patients without tumors on PET-CT post-operatively. And those were followed up with watch and wait. And among the patients that had a residual tumor on PET-CT, 7 received radiotherapy immediately after resection, and 19 had a watch and wait approach. Among these, 7 tumors showed progression. So you can see that the patients that had a positive PET-CT after resection were different were similar to patients that did not have a positive PET-CT with regard to age, sex, tumor localization, the histological subtype. But of course, they differed with regard to surgeon estimated extent of resection. So all patients with grade 4 resections that had a residual tumor were correctly identified by a PET-CT. But interestingly, half of the tumors that the surgeon defined as completely resected still showed a positive PET signal after resection, compared to a less clear picture among comparing MRI and PET-CT, where the patients that had a suggested tumor residue were PET positive in 86%, PET negative in 14%, and even among the patients where MRI showed no residual tumor, about 1/3 still had a positive PET-CT. So this is where the groups actually differed. And of course, only patients with the suspected residual tumor were offered radiotherapy. So does this play a role, especially these patients? Is there a prognostic difference? And in this cohort, they could show that there is. So if you look at the entire patient cohort of 46 patients, those that had no tumor remnant on PET-CT did not have any recurrence of tumor over the time of follow-up, whereas the patients that had a tumor remnant on PET-CT had the tumor progression in so many cases that it reached statistical significance even in the, for meningioma, relatively short follow-up of 5 years. They also looked at subgroups, so taking out those patients that were treated with radiotherapy. Of course, this could possibly mudden the analysis. So these were only patients treated with a watch and wait approach, where the surgeon was confident that there should not be any meningioma growing in the time soon. And also there, only patients with a tumor remnant on PET-CT had recurrence, the others did not. Interestingly, especially the subgroup of patients with estimated complete resections also had recurrences if there was a tumor remnant on PET-CT and not if there was no tumor remnant. In contrast, if you substitute the patient, if you subgroup the patient by tumor remnant on MRI, there was no statistical difference of who would show tumor progression. So this is a visual representation of what this would look like, a preoperative MRI and postoperative MRI, where there was no clear residue, but within the dura near the sinus, there was a positive PET signal. And if you fuse the MRI several years later with the tumor recurrence, you could see that it overlaps with the original PET positive area. This is not the only group, of course, that looked at extent of resection in meningioma and had some ideas how to possibly improve follow-up and local control. So similarly, the Copenhagen group also proposed a system to grade meningioma resection and to take biopsies around the visible tumor in pre-specified areas circularly around the tumor, as well as in any area of doubt, and then classify the tumors according to histopathology, with free margins being 0 and margins with tumor cells being 1, and also radiological imaging, where they include both MRI and PET if there's any tumor suspect tissue present. And if both correlate as no residual tumor suspect, they would recommend DOTATOC and MRI after 1 year. And if this is still negative, they would do a very long follow-up with only imaging at 5 and 10 years. If both histopathology and imaging suspect a tumor residue, they suggest to consider another resection, radiotherapy, or adjuvant therapy, or an individually tailored follow-up. And the medium ground, where one of the parts suspects a residual tumor, they suggest a slightly closer follow-up at 3, 5, and 7 years. I think this goes in a similar direction, but of course it remains to be seen if this will actually improve patient counseling and patient management. So this is in the process of sampling. Similarly, also the Munich and Salzburg group are proposing a PET guided biopsy study of possible tumor tissue within the dural tail, and as far as I know, also looking for collaboration partners. So sum up this this presentation, DOTATATE PET, from how I read the paper, does improve extent of resection assessment and is of prognostic value for meningioma grade 1 patients. Of course, the clinical impact beyond being interesting to know is still a matter of debate, because of course we all know that PET is expensive and is not very easy to acquire, especially in remote regions. And it will have to be seen how many control MRIs may actually be skipped in negative patients. So in order to be cost effective for that even that first PET-CT after resection. And also, if it's positive, do we offer re-resection? Do we treat with radiotherapy? How big is the risk to offer over-treatment to patients that would maybe not actually have had a recurrence? So this, I think, will remain a matter to be discussed in the future. Thank you.
Well, thank you, Dr. Quach. Thank you for the second quite nice presentation. Before we start discussing your presentation, before I forget it, I owe everybody an answer to the question of intrabeam or intraoperative radiotherapy for gliomas. There was a trial, and there's an ongoing phase 2/3 trial comparing intraoperative radiation for glioblastoma with post-op radiation. That's an international trial. The name is Intrago. It is led out of Montreal in Canada and Mannheim in Germany, and results are expected by mid-2026.
Well, thank you.
So I hope the person who asked the question in the chat or in the question answer section now has gotten the appropriate answer. Okay, so back to the meningiomas. As you know, I like meningiomas very much. But still, Dr. Kerschbaumer, maybe you want to ask the first question.
No, it's no real question for that. The clinic in Munich is known for their investigations in PET using in glioma as well as they do in meningioma, and they do it extensively. I'm on your side, Dr. Quach. I'm not sure whether that is pure interest or if that translates in real benefit for the patient. I think the technique per se is really good, especially in skull base and parasurgical location where the MRI has its blind spot. So we use it on demand there, and given these series. It's a tool that can help us to counsel the patients. Still, if that is of a big use in every grade 1 meningioma, I'm not sure. So personally, we suggest to do that if we think about radiation. So for a better delineation of the target, that is a clinical use where we go for a gallium dotatate PET, but not for pure counseling, because one would not expect that you have to make a decision right away. So if you suspect a recurrence, you also can wait for some time, see whether it goes before thinking of an immediate treatment.
Exactly, and I think the question from the audience goes into a similar direction, which was whether this examination is affordable. Of course, this is relative. This is an expensive examination, and to do gallium dotatate PET, you need a cyclotron on site to synthesize the substance. So this is restricted to specialized institutions, and I think it would need several, it has the cost of several MRI examinations. I'm sorry, I did not look the exact cost at the moment, but also there is some light on the horizon, because there have been, there are traces of a newer generation that will probably lower the cost a bit, because they do not have to be synthesized on site, because they have a longer half-life and can be applied similarly to amino acid PET, which is a little more common than this specialized dotatate PET. I
I
hope
just looked it up on Wikipedia. It says that it costs between $1,300 and $3,400 one investigation.
I
But
think
you
it's
need
not that expensive in Germany compared to the US,
you need a
right?
cyclotron, because
As far as
we
I know,
do the
it's
gallium
synthesized
dot PET, and you can transport that. So we have no cyclotron, but we do gallium PET in
Okay,
meningioma.
so then it's delivered the same day, right?
Possibly.
I think the half-life is like some hours. So you have to be fast. But maybe I well, maybe I overreached in this in this discussion. There was also the question of what the minimum volume of the residual is to be detected by this technique. I cannot give you an exact number, but maybe this does help you to get an idea. This is actually really very sensitive. So a few millimeters of really true meningioma tissues should be enough to at least give you a signal. But of course, there's also some background activity of, for example, the skin, where like 2 or 3 millimeters would probably be difficult to detect.
I have no personal experience with the technique, but I read the papers with great interest. So just one principal question. This whole investigation works if the tumor is expressing sandostatin receptors, right?
Mm-hmm.
And is there information out there if all meningiomas, some meningiomas, which meningiomas actually express sandostatin receptor? Mm-hmm.
Okay, so especially for the grade 1 meningioma, the expression rate is extremely high. Several series report 100%, and the lowest number that I have read was 70%. With the grade 1 meningioma, from clinical practice, I have not seen a meningioma that did not express it to some extent. But the higher grade meningiomas tend to be a little more diverse. They tend to lose the receptor in some cases.
My second question or comment alludes a bit to what Dr. Cashbaumer said when he mentioned that skull base, superior sagittal sinus, these are the areas where this technique might be worthwhile. Maybe you can comment on that as well, since I guess we all know this is a very expensive technique, and if you don't have the facility on site, there's lots of hassles that have to be taken into account if you want to have that investigation. So what are the questions that what are the patients that we need to select for this investigation? Probably not everybody with a grade 1 meningiomas. I just learned that the higher grades are probably not ideal candidates.
Although the clinical need is, of course, higher in higher grade patients, right? So there's a kind of a dichotomy there. I think Dr. Cashbaumer already answered that question very similarly to what I would have said. The PET is especially good to delineate intraosseous tumor and tumor near the sagittal sinus, where the MRI has its strongest weaknesses. So in any case where it is not clear whether complete resection was achieved, especially in these areas and where the MRI is unclear, that would be a case where I would consider doing dotatate PET. And also, of course, in cases where a radiation is planned, because the extent of radiation is much easier to delineate with dotatate PET. There are also papers about that, but of course we are a neurosurgical team here, and I did not prepare those in much more detail. So there are 2 more questions in the comments. I think this technique distinguishes residual disease from scar tissue. What is the rate of false positive and false negative, if there is any? Let me just check. I think I prepared that. No, this was not it. This was it, right? So
Looks like it, at least from the Rachinger paper.
Yeah, of course, this is not a very high sample size, but from and they didn't calculate the percentage of false positive and false negative, just sensitivity and specificity. But if the PET says no tumor, there were very few patients where there were tumor cells, and this is on a cellular level, right? No, if the PET says no tumor, there were few patients where there were even tumor cells detectable. And you have to keep in mind, of course, in this paper, they used tumor resection areas, and they could not go very far away from the original tumor and take a sample of healthy tissue, as that would have been unethical. They had to include areas that were in question, right? So I hope this answered the question. And comment on DOTA-TATE radionuclide treatment as salvage treatment in unresectable residuals. This is a very interesting and I think promising subject, where of course the imaging is necessary to evaluate which patients are eligible for this kind of disease, for this kind of treatment. I think this is promising, but of course, so far there are many good treatments for meningioma that we have, and the patients that were treated with these experimental treatments are in a very late stage of their disease. So the data on this are mixed, but it does seem that if often these were the multifocal tumors that were operated on several times. But it seems if there is pre-treatment high signal in DOTA-TATE PET, then the treatment stabilizes tumor growth and also causes tumor shrinkage. But there, especially, it is important to differentiate which tumors within the same patient actually express how much of the receptor, and the optimal threshold who would benefit and which tumor in each patient would benefit from this treatment. This will still need to be defined in the future.
Thank you. Dr. Kerschbaumer, any final comments?
No, I think all has been said. I'm not that convinced about the therapeutic use of gallium, at least in our personal experience. So it's the last resort when you have no other treatment options. Of course, that may misguide my feelings about that treatment, but I have not seen in our institution so far really good results of that, even if the idea behind that, of course, is quite interesting.
I think patient selection may play a role here. I think we should not discard this line of treatment.
No.
Of course, I mean, we have so little to offer to meningioma patients who are refractory to other forms of treatment. So of course we will have to see what that works out. My personal view would be that I'm not sure that, I mean, I'm a true believer in the extent of resection and meningioma surgery, and I like very much to use the Simpson grading, even though it can be criticized for several reasons. So there's one side in me which feels, yes, we need something that, I like the data, so there's a technique that shows residual tumor, and it is better for the patients to take it out. On the other side, looks like it's very cumbersome, and indeed, the delta that can be delivered to the patients by widely applying the technique might indeed be limited. I find the radiation thing intriguing, that, you know, if you have to delineate your radiation area, the area that has to undergo radiation, maybe these are going, especially in the skull base, maybe, or if you have something complicated, maybe at the superior sagittal sinus, then maybe that technique might find some applications in the near futures. That would be my current state of thinking about this technique, and then we'll see. All right.
Mhm.
Looked like you're happy, Dr. Quach, Dr. Cashbaum was happy. The audience is happy because here my computer says no open questions. And I guess then thank you to everybody. Thank you to the audience, and thank you to everybody who participated in the discussions. Of course, thank you very much, Dr. Quach. Thank you very much, Dr. Cashbaum, for preparing those really excellent presentations. I learned a lot, and I liked the discussions, and thank you very much. And I guess we're all seeing each other in Sofia in a very few weeks.
Thank you.
Thank you too.
Bye-bye.
Bye-bye.
Bye.